Hello, everyone. Thanks for joining us tonight. We're just going to give it a few minutes to get started. Let everybody get a chance to get into the webinar. All right. Hello, everybody. Good evening. Thank you for joining us for our colorectal screening webinar. This is a program that's brought to you by Mayo Clinic, the Coalition of Blacks Against Cancer, and also the Phoenix chapter of the Links, which is a community-based organization that received a grant to help educate the community on colorectal cancer. So my colleague and I, Dr. Sarah James, are both radiation oncologists at Mayo Clinic, and we want to share some information with you tonight that we hope will be very helpful for you as you're learning about how to take better care of your own health. And also, we're deputizing you as ambassadors, health ambassadors. We want you to go out and spread the information about colorectal screening to all your family and friends. So I have a short presentation that I'm going to be sharing with you, and then we will take any questions if there are any. You can put them in the chat or question and answer. So this is entitled Colorectal Screening, What You Need to Know. Dr. James, I'm hoping that you can see my screen.
Yes.
Great. So the question that people may ask is, what is colorectal cancer? And the first question is, what is the colon and rectum? And this is a little cartoon that shows what the bowel or the colon is, and all of us have one. And so the vast majority of the bowel is called the colon, and right at the end of the colon is your rectum. And colorectal cancer is a cancer that starts in the colon or rectum. And what we know about what a cancer is when cells in the body start to grow out of control. And with colorectal cancer, as with other cancers, these cells keep dividing and growing, and they forget when to stop growing. Most colorectal cancer starts from a polyp or a growth in the colon. And that's why screening is important, is to try to pick up these cancers before they become advanced. So what are some of the statistics? Colorectal cancer is the third most common type of cancer in men and women. And most people are under the age 50. But Chadwick Boseman, who's pictured on the right, is someone that I think we all know with Black Panther and all the other wonderful things that he has done. And he really elevated the awareness of colorectal cancer within the Black community. Unfortunately, with his death from colorectal cancer, he was a young man and certainly less than 50. So one take-home message is that, even if you're young, you can be at risk. The highest incidence of colorectal cancer occurs in the African American population, and like with many other cancers, the death rate is higher than other populations, and some of that has to do with later stages at diagnosis. Take home point, the earlier you catch a cancer, the greater your chances are of being cured. The good news is that the disparities between Black and white patients are narrowing, in that the death rates are coming down for all populations in colorectal cancer. And some of that's due to increased screening and also people making lifestyle changes. So what are the risk factors? Many people always say, is there something that I can do to try to reduce my risk of a cancer? And colorectal cancers are one of those ones where we have what we call modifiable factors, things that you can take into your own hands. We know that a diet that is low in fiber or high in fat predisposes you to colorectal cancer. Now, all of us may eat some things that perhaps we shouldn't every now and then, but really paying attention to what you're putting into your mouth, what's going into your system is really important. We know that a lot of red meats, we also know that processed foods like cold cuts, hot dogs, things like that can put you at high risk for colorectal cancer. And cooking meats at very high temperatures, such as with grilling, may also predispose. What we want to increase in our diet is what we see in the picture on the right, a lot of fresh fruits and vegetables, things like bananas, broccoli, beans, whole wheat. Those types of things help to put more fiber or roughage in our diet and reduce the risk of colorectal cancer. We know that also low levels of vitamin D can also increase the risk of colon cancer. And vitamin D is one of those vitamins that you can get from being in the sun, but you can also get from drinking things like fortified milk or orange juice that's fortified with vitamins and things of that nature. And many of us have low levels of vitamin D and don't even know it. So as you're seeing your healthcare provider, ask them, should you have a vitamin D level checked? A sedentary lifestyle, which can lead to obesity, can put you at risk for colorectal cancer, as can smoking and alcohol. There are certain factors, however, that are not modifiable. You certainly can't modify your age, no matter how much we try to turn back the time. If you're over 50, that puts you at risk of colorectal cancer. Although, again, as I said previously, you can get colorectal cancer at a younger age. Also, we know that there's certain people that have either a personal or family history of multiple colon polyps or colon cancer. And if you've had one bout of colon cancer, that can put you at risk for more colorectal cancer. And also, if you have certain types of colon polyps that predispose you to colon cancer, you can be at risk. Also, there are people who have what's called inflammatory bowel disease. There are two types of diseases, including ulcerative colitis and Crohn's disease, that can put you at increased risk for colorectal cancer. There are certain inherited syndromes that have to do with the bowels, such as something called Lynch syndrome, where you have multiple polyps, or familial polyposis, again, where you have multiple polyps that can put you at risk. And also patients with type 2 diabetes are at increase of colorectal cancer. So let's talk about the colorectal screening guidelines. These are really important to know. What are the guidelines? For average risk people, and we'll define what average risk means in the next slide. For average risk, the recommendations have dropped so that we recommend that people start colorectal screening at age 45. It used to be age 50, but now it's age 45. We recommend that you continue screening through the age 75 if you're in good health and life expectancy is greater than 10 years. From 76 through 85, the decision is based on personal preference, health, and life expectancy. If you have a lot of diseases, a lot of poor health, and you're not likely to be around for 10 years, then perhaps colorectal screening is not what you should be doing. And the recommendation is that age over 85 should no longer get screened. So it's really important to talk with your healthcare provider, but it's also important for you to know what these screening guidelines are, because we know from studies that African Americans are sometimes not reminded or told that they need these screening studies. And so we can't always rely on our doctors to remember or to tell us. And so we really need to take it into our own hands to know when we should be screened. So what does average risk mean? So these guidelines that I talked about, what does average risk mean? Average risk is somebody that doesn't have a history themselves of colorectal cancer or a certain type of polyps that predispose you. And polyps are growths in the colon. So if they have certain types of polyps, it can put them at higher risk. A family history of colorectal cancer may put you at increased risk. As we talked about, a personal history of inflammatory bowel disease, which is ulcerative colitis or Crohn's, suspected hereditary or known hereditary syndromes or diseases that put you at risk for more polyps that can turn malignant or cancerous, and also a history of radiation therapy to the abdomen or pelvis for a prior cancer, such as a prostate cancer or cervical cancer or other cancers that can happen in the abdomen and pelvis, that can predispose you to developing a colorectal cancer. So it's important that you talk with your healthcare provider about what's the best type of screening for you. When we actually think about cancer screening for colon and rectal cancer, many of us just think straight away about a colonoscopy. But there are a different number of approaches that can be used. You can test the stool. One is called a fecal immunochemical test. It uses antibodies to detect blood in the stool. And so basically take a little bit of feces and put it on a card, and they check the whether there's any kind of blood in the stool. There's also a guaiac-based occult test that could be done every year. And there's also what's called a multi-target stool DNA test, which can be done every 3 years, which detects DNA in the stool. And this is a relatively more recent development. And then there are what we call structural exams, where we have a colonoscopy, which is where a thin, long, flexible lighted tube is inserted into the rectum and can go snake all the way through the bowel looking for polyps. And that the recommendation generally is that to be done every 10 years, unless something is found where the doctor feels that you need to have a repeat one sooner. For example, they may find some polyps that they want to make sure that they don't regrow or things of that nature. We're now getting to the point where we can do a CAT scan colonography, which can be used every 5 years. And a CAT scan is a particular type of an X-ray test that's non-invasive, meaning the X-rays don't go inside your body, but it scans you from the outside, and it gives almost like a three-dimensional picture of the colon. And basically, the gastroenterologist can actually look to see if there's any polyps or other abnormalities that may later need to be further investigated. And then there's also something called a flexible sigmoidoscopy. So instead of going all around the colon, only half of the colon can be reached with a shorter scope called a flexible sigmoidoscopy. And that sometimes can be used every 5 to 10 years with the fecal immunochemical test testing the stool yearly. So there are a variety of different ways of screening. And again, ask your healthcare provider what's best for you. So I wanted to just talk about what does a colonoscopy entail. So again, it's inserting a thin tube that is attached to a scope that the doctor looks into the rectum, and it snakes around the colon. Now, when patients have a colonoscopy, they usually are asked to use what's called a PrEP, which is like a laxative that really cleans you out because you don't want to have any stool left in the colon or the rectal area, but particularly the colon area that obscures the view of the doctor. Also, you undergo light sedation, meaning that you're given an IV when you go in, and they give you a little drug that kind of puts you in what we call a twilight sleep. They don't put you under like when you're having major surgery where they have to put a breathing tube down and all of that. It's more like a light sedation. And the colonoscopy really doesn't take a long time. They do it, you're out, you don't remember it, you wake up, you think, has it been done yet? And then you take the rest of the day to recover, and you're back as good as new. And this in the upper right shows you a picture of what the gastroenterologist might see, where they're looking at the inside of the colon, which looks like a long tube. So I want to play this video, and hopefully we'll get it to play. And it's going to talk about what a colonoscopy entails.
Colonoscopy is used to detect early growths called polyps in the colon. These polyps or growths start in the lining of the mucosa. That's the covering of the colon, which starts from the anus or the rectum and extends all the way to the cecum, which is the beginning of where the small intestine dumps your food for it to be transported out as feces. This feces blocks our view, so before showing up for your appointment, it's very important that you follow the directions provided for your bowel preparation. Bowel preparation is an electrolyte solution along with some medications that allow your body to purge or to have a diarrhea. It's very important when you take this solution that you drink it all and follow the directions provided by your pharmacist and also physician, because without being able to clean out appropriately, your doctor, your gastroenterologist will not have the opportunity to see the colon well to detect these early and sometimes very small polyps that can lead to cancer. After adequate bowel preparation, you would present to a facility in which an intravenous or IV will be placed for medications and also for fluids, along with the potential of an anesthesiologist or also a nurse that will provide medications for sedation. In many centers, this is done with medications that put you in a twilight or a light sleep. We call that moderate sedation. And in other facilities, we also do this with a more deep anesthetic called propofol, which allows you to sleep during your procedure without being uncomfortable. It's important in order to see in this colon that we use a long lighted tube along with air and sometimes CO2 to open up the colon so that we can see all of the walls. If a doctor identifies a polyp in your colon, it is possible to remove this by a number of ways. The most common way is to use a biopsy forceps. It's very small, or larger polyps can be removed with a snare loop. It's a small wire that can be placed around the polyp and then removed by clipping it either with electricity to burn in that space, or to just essentially chop that polyp away from the colon wall. This provides a very safe and effective way to remove and to take away any colorectal polyps or cancers that may be found during a colonoscopy. There's another test in addition to a colonoscopy that allows complete evaluation of the colon, which is termed a CT colonography or CTC. This entails continue to drink a PrEP, but it does not associate itself with any risks associated with sedation. This is something that can be done by a radiologist and also evaluate polyps throughout the colon. If something was found during those tests, the recommendation for those patients are to undergo a complete colonoscopy for removal of any polyps that are identified. We know that with the use of colorectal cancer screening and also direct viewing of the colon with colonoscopy, that we've decreased the incidence and the impact of colorectal cancer. So it's very important that you and your loved ones talk about the need for screening and also adhere to the surveillance protocol set forth by your doctors after you've been screened.
All right, so hopefully that gave you a little bit more insight about colorectal cancer screening with colonoscopy. So let's recap our takeaways and recommendations. First of all, we need you to understand your risk. And for those who have an average risk, meaning that you don't have a history of colorectal cancer yourself or no family history, or you have no genetic diseases or conditions that predispose you to colorectal cancer, or you have nothing else that puts you at higher risk, average risk screening starts at 45. By 85, you can stop screening. From 76 to 85, it depends on your health, but generally between 45 and 75, one should be screened as long as you have good health and a life expectancy of 10 years or greater. It's important for us all to address modifiable risk factors, Eating a high fiber, low fat diet, avoiding smoking and alcohol, and trying to keep our weight under good control through getting exercise and not being so sedentary like we all can be prone to do at times also can help reduce your risk. Know your family history. Know if there's a history of colorectal cancer or polyps in your family. Sometimes we don't always talk about what goes on in our families, so it's important that we know our risk. Talk to your healthcare provider about which screening tool is most appropriate for you. Understand their recommendations. And if you don't understand, question, but also bring it up. If you're 45 and you haven't had a discussion with your healthcare provider about starting colonoscopy screening, ask them about it. And the last one I think is mostly important. Don't have fear. For those of us who've had colonoscopies, is it the most fun thing to do? No, I can think of many other fun things to do, but you're really getting a sedation. In general, for most people, that's low risk. You don't know that you've undergone the procedure and it could save your life. And if there's something that's found, address it. If there are polyps that need to come out, or even if they find a cancer in there, which most people, they don't find it, but if they do, early diagnosis is very, very, very important to increase your survival. So with that, I will open it up to questions, and I hope that this has been informative. And remember, we've deputized you as health ambassadors. And so if you have any friends or family members that you know could benefit for this, we're going to be creating a YouTube link and posting it to the Coalition of Blacks Against Breast Cancer. We'll also send it out to participants. Dr. James, any comments that you would like to make?
That was a very good overview and review of what's needed for colorectal cancer. And I just want to reiterate and stress the importance of discussing family history. And it's something that a lot of times we don't discuss our medical histories with our families, but very important for risk reduction, not just in colorectal cancers, but in all cancers.
Thank you, Dr. James. Important information. So if you have questions, we invite you to put it either in the chat or in the question and answer section. And we'll just hang around for a few minutes so that we can answer questions. We wanted to leave plenty of time should you have questions for us. So the question is, as an breast cancer survivor, is there a correlation between breast and colorectal cancer? And that is a wonderful, wonderful question. Dr. James, would you like to answer that question?
So there is not a direct relation. However, genetic risk, if you have a genetically inherited cancer, there can be risk for other cancers, and those are the ones that would put you at higher risk and would make you want to talk to your provider more about earlier screening and the best and appropriate screening for your situation.
Yes, and only about 5 to 10% of breast cancers are inherited through a specific gene. And one of those, or two of those genes, BRCA1 and BRCA2, do put patients at increased risk for colorectal cancer. So if someone had a genetic mutation that predisposed them to breast cancer, or even Lynch syndrome is another one, they should really talk to their doctor about when and how often they should be screened, because that is taking you out of that average risk and putting you into a higher risk category. So wonderful question.
Mm-hmm.
Any other questions out there? Okay. Well, seeing none, we hope that this has been informative. If there are questions that you would like answered, we would be happy to funnel them through the Coalition of Blacks Against Breast Cancer info at cbbcaz.org. Please reach out. Please share the information. And thank you so much for joining us this evening. Good night.